All right, good evening, everybody. My name is Evan Chang, one of the ophthalmologists at Inglewood Hospital. My office is actually in Tenafly. It's just down the street on Dean Drive, maybe about a mile north. This talk tonight is kind of designed to just kind of get you familiar about some of the certain eye conditions that I see. It's designed to be super casual. If you have any questions, feel free to raise your hand. There are kind of some design breaks in between the sections about each topic and stuff like that, so you can ask your questions then. That would be maybe a little bit easier, but otherwise, feel free to stop me. Again, super casual, don't worry. So we'll get started, okay? So again, my name is Evan Chang. A little bit about myself. I'm a Jersey boy. I grew up in New Jersey, specifically Union County. I went to Summit Public High School. I went to college at Johns Hopkins. I was recruited to play baseball out of there. Kind of one of the reasons why I became a doctor is I actually had a sports-related injury in college, and that kind of promoted me to kind of go down the medicine path and become a doctor. But eventually I found my way to eyes, since I thought the surgery was very elegant. I can help a lot of people, and a lot of people care about their vision. I went to Rutgers for undergrad, specifically Robert Wood Johnson in New Brunswick. Spent 4 years there and did my surgical training out in California at UC Davis. And then I found myself back here. My wife is also a doctor. We met in medical school, and she is currently a pulmonologist at Memorial Sloan Kettering. So that's kind of why we're back here in the area. But we're looking to set roots and stuff like that. And Inglewood Hospital's been pretty good to me so far. I've been on staff for about 3 years, and same thing for at Tenafly Eye Associates. All right, so what are the most common things that I see? I think the 4 things that we are going to hit tonight are cataracts, glaucoma, macular degeneration, and diabetic retinopathy. Again, so these are 4 sections. At the end of each section, feel free to raise your hand, ask me some questions, and we can talk about it. All right, so before we kind of get started, we're on to a quick anatomy lesson. So when you look at the image on the left of the little packet that you guys have, right? So the cornea is actually the clear surface of your eye. The iris is the color part of your eye. So I might have to share with some people. Some more packets there, excellent. Yeah, sure. So the image on your left, that's kind of just a photograph of someone's eye. The cornea is the clear surface of the eye. It's kind of like the windshield of the eye. It's very clear. You don't actually see it. That is actually where we do laser refractive surgery. People that want to do LASIK or PRK so they don't have to wear glasses, that's actually what we're doing surgery on. The iris is the color part of your eye. Some people have blue eyes, green eyes, I have brown eyes, but that is the muscle that kind of opens up the pupil, which is the hole that allows light to enter inside the eye. So the eye is kind of like a camera. A camera has a lens and the body that houses the film. So when light comes through, the lens focuses it, and then the body with the film captures the light, turns it into an image, and that's how we create a photo, and that is how our eye works and creates vision for our brain. So these are pictures here. The right image on your little packet. Yeah, one more. Yeah. So that's actually what happens when you come into the eye doctor's office. It is called a slit lamp. It's basically a microscope. Because your eye is so small, we actually have to use a little microscope so that we can see your eye. We use light, and we use it in certain ways to analyze different parts of your eye, and that's kind of what the top left image is showing, a little slit beam or vertical beam of light that goes through different parts of your eye so that we can look at it and examine it. And then the bottom left image over there, let me just turn this over for you guys. This is actually your retina, which is actually inside of your eye. That is like the film of the camera. And that's what captures the light, and that's what turns it into an image. And this little guy right here, that is your optic nerve. The cable that connects your eye to the brain sends all the electrical information back and forth. All right, so now that we got kind of a grounding of where we are in terms of the eye and the anatomy, let's start with cataracts. So cataracts. I'm sure a lot of people, maybe you've had cataract surgery, maybe you know someone that's had cataract surgery, friends, family, that sort of thing. Unfortunately, it's one of those things where everyone gets it. If you live long enough, you do get cataract. It's just a natural process of the eye getting a little bit older. So our clear lens, which is located behind our iris, the color part of your eye, It is normally clear when we're younger. It allows light to be focused. It has some flexibility. That's why when we're younger, we don't have to pull out reading glasses or get progressives or bifocals, because we can overpower our vision and look up close. Or you've never worn glasses, and then all of a sudden you have to wear reading glasses because your natural lens at around 45 starts to lose its flexibility characteristic. And that's why you can't dial in that power anymore. That's why you just can't over-focus your vision, and you have to get the reading glasses or go into progressives and bifocals in order for you to see. And unfortunately, around 50, it really starts to go downhill, and then we're constantly grabbing it. So what is a cataract? That is that natural lens that we're talking about. It's no longer clear. It becomes this cloudy, milky, yellow, brownish substance, and it doesn't allow your eye to focus anymore. And at some point, glasses outside the eye no longer solve what's going on inside the eye, because again, the cataract is inside the eye. You've probably seen photos of dogs. If you've ever grown up with dogs, I love dogs. I have a dog. When they get a little bit older, right, all of a sudden their eyes get a little white. That is a cataract. Dogs also get cataracts. Cats also get cataracts. So there have been people do cataract surgery on animals. There are veterinary ophthalmologists, and where I did my surgical training, there's the two best veterinary schools in the country are Cornell and UC Davis, and so they do some crazy stuff in terms of animal care, which is cool. But we're not alone when we get cataract. So this is a photo of my wife. We went on vacation last year. This is in Istanbul. This is in the spice market, and it's designed as a normal photo. You're just kind of looking down. Just imagine yourself in the hallways, just in a shop and stuff like that, going around. So this is kind of a normal photo. But what happens when you start to get cataract? And there are different grades, right? It's not just like, boom, you all get a cataract. It is a slow and gradual progression. So the next photos, I hope it's in color for you guys, is that over time, it turns into this yellowish hue. You start to lose some of the definition with your vision. It's just not ultra clear anymore, and you start to lose a little bit of your depth perception. The process happens over, sure. The process happens a little, very slowly, so you don't necessarily notice it. But over time, the most common complaints when your cataract you feel like is ready, difficulty with nighttime driving. Just the lights, oh my goodness, you have all those streaks of lights that are coming out. You've got the halos. Forget about if it's raining out. With the rain and the headlights, the glare is unbearable. Most people, when I tell them, oh, you've got some slow cataracts, some small cataracts in there, do you have any issues with driving? Yes, it's a little difficult, but I don't feel unsafe. Do you feel unsafe driving at night? Can you see the street signs? Can you see the exit signs on the highway? When you make a right-hand turn, are you bumping into the curb, or can you actually see where the curb is? Do you see the double median line? If you cannot see any of those aspects with your vision, particularly at nighttime driving, you are ready for cataract surgery. Another common complaint is that it's very dark. When you're at a restaurant, all these restaurants, right, they have that low ambiance lighting. It's very difficult to see the menu, right? You see everyone kind of grabbing their phone for a light to, increase the contrast so that you can see the menu. That will be very difficult when you have cataracts. You just feel like, I cannot get enough light in order to see the menu at the restaurant. So these are very common, day-to-day things like, oh, I just don't see very well. So what do we do? Cataract surgery. Unfortunately, there are no eye drops, there's no medicine, there's no supplements that will reverse or prevent or slow down the progression of cataract, because again, it is a natural aging process. You're kind of asking for something to stop your entire aging. I wish it was true, but unfortunately, there's no silver bullet to stop a cataract. So again, we have to do surgery. Surgery is done in the outpatient setting. At Inglewood Hospital, we have an outpatient center. It's the Barry Center. This is not overnight surgery. The surgery itself takes maybe about 10-15 minutes at most. It is light sedation. It is not general anesthesia. You do not have to go fully under. There's no breathing tube. There's no cardiac bypass. This is not open heart surgery. It is just cataract surgery. Again, it's about 10-15 minutes. We do one eye at a time. Basically, I'm going in, removing that cataract, and the cataract is actually kind of like a peanut M&M. A peanut M&M has the shell, the chocolate, and the peanut, and then what I'm removing is the chocolate and peanut and replacing it with an artificial lens. Yes?
So you were saying that while you were doing that surgery, aspirin or
You get light sedation. You get a medication through an IV that relaxes you. If anybody's taken like a Xanax or Valium or Ativan, any of those types of medications, it will make you very sleepy. It kind of feels like you had 4 or 5 glasses of wine, just to kind of take the edge off. Most people do not remember the experience. They get the medication, they fall asleep, and they wake up, oh wow, we're done. 10 minutes, that's all. Yeah, just have to stay still for 10 minutes, I'll do my thing, and then you're gone. Yeah. So again, right, we're removing the cataract that's inside of your eye, replacing it with an artificial lens, and that is how you see again. It's a great surgery. The beauty of cataract surgery these days is the incisions are so small, just like belly surgery, kidney surgery, GYN surgery. It can be all robotic with very small incisions. Our incisions are 1 millimeter wide and 2 millimeters wide, incredibly, incredibly small. Sometimes we have to use stitches. The stitches are smaller than your hair. So that's why it's microscopic surgery. But modern day cataract surgery, we don't even have to use stitches. Everything heals up on its own. That's why the recovery time is so quick. On average, about 2 to 3 days after cataract surgery, that's when your vision starts to really come into focus. That clarity, that brightness, the colors. I would say most people say that the colors are the biggest shocking aspect after cataract surgery. Reds look like reds, blues look like blues, the greens, everything is very bright and vibrant. I've had some people come back to me after cataract surgery and they say, wow, I have to get new sheets, I have to get new curtains, everything's yellow and dirty. I didn't realize it, and now I can see again. You're making me spend more money and getting more curtains. Yeah. So, yes?
what's the lifetime of the
Once the lens stays in, it does not need to be replaced. It stays with you for your lifetime.
one time?
Yep, unless you happen to get into a bar fight, a bad car accident, there are certain scenarios where we can replace it, but for the majority, say 99% of the time, it goes in and stays in. Yep. Correct. So this slide right here is, we have different types of implants these days. They are kind of broken down into 3 major categories. We have single vision, multi-vision, and adjustable vision. Single vision, this is what the majority of patients choose because it is covered by insurance, it is covered by Medicare. It gives you good single focus vision. What I mean by that is that if you were younger, let's say at 45 or so, you could see far away, but you had to always reach for reading glasses. I can restore that so that without glasses, when you watch TV, you go out to a play, looking at a face across the street, when you drive, you should be relatively glasses independent. Just look like that off in the distance. And then when you need to read, just go to CVS or Walgreens or the dollar store, pick up some $1 or $2 reading glasses, and just like that, and that's it. So it's a great lens. It's what the standard of care is, and it restores a lot of people's vision. The 2 other categories are designed for people that do not want to wear glasses after surgery. The second category is multi-vision. It is a lens designed to give you a range of vision so that you don't have to reach for the reading glasses when you're on the computer or at the restaurant. It gives you good distance, computer, and reading. Unfortunately, that one is not covered by insurance. It's considered a cosmetic upgrade. Same thing with the final lens, the adjustable vision. This is probably the coolest technology that we have. The lens is made of a special material that reacts to light. Once it gets implanted inside of your eyes, I can adjust it to however you want to see. It's like buying a suit off the rack and going to a tailor and have everything custom made to measure. Whatever you want to see, I can change it to however you want. Because of the technology, it's definitely not covered by Medicare, but it's a great lens if you really do not want to wear glasses after surgery. Again, it's designed for people that really want to have control of their vision. But again, about 75 to 80% choose the first lens. Great. It's a great, wonderful lens. Sorry? It varies from place to place. Different doctors and offices charge a different price, but the multifocal lens is around $2,000 and the adjustable lens is around $4,000. Yeah, it's because of all the technology that's kind of gone into it. And like I said, 75 to 80% of patients, standard lens, you're going to have great vision. Yeah, yes, please.
Yes, so I had surgery.
Yep.
And I was able to, I needed glasses for distance,
Mm-hmm.
but to read up close.
Yeah.
I didn't
So that's also under the category of single vision. There are a minority of patients, like myself, I'm nearsighted. I can see up close without my glasses. But in order to see all of you, I must wear glasses so that you're in focus. There are certain people that after surgery, they want to stay like that. So I can use our standard lens and bring your vision up here. But your driver's license will still say needs corrective lenses to drive. So it's what you want to do. I've had plenty of jewelers, for example. They work on fine jewelry. They want to have their vision up close without glasses. But when they watch TV, they watch with glasses. So yes.
What is the difference? Handmade surgery or robotic surgery? Cataract.
So there's no robotic cataract surgery. There is laser-assisted cataract surgery. In my opinion, it's kind of equivocal or equivalent. The laser is designed to assist in certain aspects of the cataract surgery. In my opinion, I feel like my hands are pretty good and I don't need the assistance of laser. So that's just personal preference.
Because it's a big center, they say, if you want cataract surgery and you want laser assistant, you have to pay additional
Correct.
$2,500.
Yeah.
And everybody agrees, because this is the eyes.
Yeah.
People are afraid.
Yeah. Personally, I feel like I'm pretty good without it, so that's why I don't normally use it. Yeah. So it's just personal preference on the surgeon. Yep.
So I also want to say that my vision is completely flipped because of it.
Correct.
Now I need glasses to read, and I don't need it for distance. It's taken me a while.
Sorry?
It's taken a while.
Yeah.
You know, I thought it would be an easier adjustment,
Uh-huh.
but it's not. It's not. It's taken a while for me to get used to, because for years I just had to pick up, magazine and book. Now I have
To bring the readers.
glasses everywhere.
Yeah. So that's why there's no one catch-all for everyone, right? It's always a discussion with the patient to figure out what's a priority to you. Some people really want to go to the baseball game and not to wear glasses, and they've always worn glasses for far away. And there are plenty of people, like, it depends on what you do. Are you retired? Are you still actively working? I've had plenty of nurses that come from me from Englewood. They want to be able to see somewhat up close because all they're doing is on the computer all day long, logging orders. So we will prioritize that vision, but they still have to understand that they're going to wear glasses for far away. So again, it's not one size fits all. Everything's a discussion with each patient. Yeah. Yes, please.
Steroids, this is known.
Yeah.
They cause cataract,
Mm-hmm.
and they are prescribed. I asked somebody prescribing steroids.
Yep.
Ophthalmologist. I said, look, it's caused cataract. Don't worry, only 2 weeks. I went to another person because this never helped me. Don't worry, it's only 2 weeks. Finally, I got cataract.
Mm-hmm.
I never ended with it.
Sorry, say the last part again?
I never had before cataract because they continuously prescribed steroids for itchy eyes.
Yeah, that's
And nobody says it to the public. Steroids cause cataract.
It depends on a few things. If you are on long-term steroids, yes. And what's long-term? It's a little bit different for everyone. They could be oral steroids. They could be topical steroids. They could be eye drop steroids, right? Everything's a little bit different. Topical skin steroids, low risk for developing cataract. If you're on long-term oral steroids, people that have lupus, rheumatoid arthritis, these types of conditions, then yeah, definitely, they can cause accelerated cataract formation. But again, everyone will get cataract at some point, and it.
The ointment for the eyes anti-itchy.
Yeah.
And it's called cataract.
Again, yeah, I'm just kind of making generalizations. Yeah.
The public is supposed to know.
Yeah. Okay.
Not like prescribed food.
So, all right. Do we have any further questions about cataract? Yes.
I see my ophthalmologist
Mhm.
every 4 months, and she says, well, I have baby cataracts
Mhm.
that are normal.
Correct.
Does that mean it's going to progress?
If you live long enough, everybody gets cataract and cataract surgery. Yeah. It's just one of those things. It's a range. I would say in my practice and with my patients, it's the average age is about 71. With that being said, I've done it as early as 14 and as late as 99. So everyone's a little bit different. Yeah. So, yes.
And so I remember when I had my cataract and they did the one eye. And when they did the one eye, it was great. It's like I didn't need glasses for anything. I could read up close and I could see. It's not until the second eye that it was done that I need the glasses. So do some people just do the one eye?
So what you're describing is what's called monovision. So one eye sees far away and one eye sees up close. Your brain automatically adjusts. Whenever you see someone across the room, your brain will use your distance eye to see the face. And if you pull out your phone, your brain will use your other eye and read. I don't normally do it in a lot of patients because once the implant goes in, I don't like taking it out. It will cause a little bit of a depth perception imbalance with your brain. So if I do it permanently, you may be completely off balance, right? So I only do it in people that have done it before, either through laser surgery, contact lenses, or have it naturally. So again, in your scenario, could it have been done that the other eye could have been left near so that you didn't have to wear reading glasses? Sure. But again, every person's a little bit different. Yeah. All right, any further questions about cataract? All right, so we are off to glaucoma now. What is glaucoma? Glaucoma is a problem with your optic nerve. That is the cable that connects your eye to the brain. Consider it like the HDMI cable that connects your TV to the TV box. It sends all the electrical information back and forth so you can kind of create an image for your brain. Again, we are talking about this guy over here, the connection between your eye and your brain. When we look at your eye, it looks a certain way. We're specifically looking at this guy right here, the optic nerve, okay? So what is it supposed to look like? It's actually supposed to look like a bagel. And we're talking about a nice, thick New Jersey bagel, right? We are not talking about a skinny-looking bagel with a big hole. We do want a small hole right here. We don't want a big hole, okay? You want to get your money's worth with a bagel, okay? So when we look at your optic nerve, right, this is a normal one where there's a small little hole here and a big bagel. This is a skinny-looking bagel with a big hole. We do not want that. That is a signal that you may or may not have glaucoma. Glaucoma is is associated with high eye pressure, but there are definitely a ton of people that have normal pressure inside the eyes and still have significant glaucoma. Glaucoma will affect your peripheral vision. So it's not your center vision. That's why it can be a little dangerous because you don't feel it on a day-to-day basis, right? You're not paying attention out over here 24/7. When you're looking, right, you're looking in the center of your vision. So we're back to our photo of my wife. You're just looking down this, down the hallway and, just taking everything in. And then over time, with the glaucoma, you start to lose parts of your peripheral vision. So when you look on the pictures, right, the edges, the other people that are surrounding, you start to miss them. Your brain doesn't think about it, right? Because your brain is so used to looking in the center, it's not used to looking out in the periphery. So that's kind of like a visual depiction of what glaucoma can be. So it isn't till the very, very end that you actually start to lose your center of your vision. So that's why it is important to go see an eye doctor, whether it be an ophthalmologist or an optometrist, to get your optic nerve looked at, to make sure that your pressure is fine inside the eyes. Just like blood pressure, right? When you go see your primary care doctor, we don't want blood pressure up in the 200s. We don't want blood pressure in the 60s. We want it in a nice range. Same thing for the eye. Anywhere from about 10 to 20 is considered normal. Yes, please. 10 to 20. 10 to 20 is considered normal. Normal, yes. Is a little concern. People in the 30s, no good. There are plenty of people that live and have never had glaucoma problems at maybe 25, 26, 27. And that is considered people with high eye pressure without having glaucoma. But everything is kind of taken into account. You could have a very looking normal optic nerve and a pressure of 28. and never develop glaucoma. And there are plenty of people that have significant glaucoma at a pressure of 10. It just depends on who you are. It depends kind of on your family. Normal pressure glaucoma is often very common in Japanese, Chinese, and Korean, unfortunately. So all right. So how do we test for glaucoma? Like I said, glaucoma is a problem with your visual field, right? It's a problem with your peripheral field. So we will formally test it in a machine. It's kind of like a video game. You put your chin in, you put your forehead in, it's this little dome, and the machine flashes lights all over the screen. And you click a button when you can see it. And then we formally assess it, and the machine gives us a reading that, yes, your visual field is intact. You know, if it's white, that means, yes, you saw the light. If it is black, then you did not see that, and you're missing parts of your visual fields. This is a scan of your optic nerve here. Think of your optic nerve like the George Washington Bridge. The cables that hold up the road and the bridge, you want those cables nice and thick. You do not want skinny cables that are holding up the road, right? So we take a scan of your optic nerve, and it spits out an image. Green is good, red is bad. Red means damage to your optic nerve, and we have to be a little bit worried about that. Green means nice and healthy, nice and thick. How are you? Good to see you. So this is an image of kind of a spectrum of glaucoma. The left images, right, that's all green. That is a normal visual field. When you start to get little problems, yellow and red, and definitely all red, then that's when you start to lose parts of your peripheral field. And that's when we really need to intervene by either treatment, which I'll get to in a little bit. But any questions about this slide? Yeah? It can be, I would say a majority is just family, just genetics. It just happens, unfortunately, with some people. You think about the eye, there's always water being produced inside the eye. It's constantly being drained as well. Just like our blood, it's constantly being circulated. Unfortunately, as we get a little bit older, the drain of the eye no longer drains as efficiently as it once did. And that allows more water to linger inside the eye and then causes the pressure to go up. A lot of our treatments are designed to lower the pressure inside the eye by various methods. Okay?
Because high pressure would damage the optic nerve.
Correct. Just like high blood pressure puts you at risk for heart attack and stroke. Kind of the same principle. Yes, please.
Why are you
Glaucoma treatment. Next slide. Ready? Yeah. So again, the goal of treatment for glaucoma is to lower pressure inside the eye. There are eye drops, there is laser treatment, there is surgery for it. In the beginning, I don't necessarily mind which option that you choose, if it's either eye drops or laser treatment. Eye drops, once we go down this route, you have to continue with the eye drops every single day. It doesn't work if you do it maybe once or twice a week. Just like blood pressure medication, you have to take it every day. The drops are designed to allow water to flow outside the eye easier and also decrease the production of water inside the eye. By these two aspects, the pressure and the volume inside the eye goes down, which will help protect your eyes from the glaucoma. Laser surgery for glaucoma. Think of your kitchen sink drain. It's Thanksgiving Day, you're frantically preparing the carrots and potatoes, you're shaving everything. All of those potato and carrot shavings are covering your sink. And you turn on the faucet, that water has nowhere to go because all those shavings are blocking the drain. The glaucoma laser procedure is designed to clear all the carrot and potato shavings so that water flows effectively through the drain. It is an in-office procedure, it takes about 3 minutes or so, very, very little pain. It's a great procedure when it works. Once we get into surgery, we actually have to cut parts of the eye. We hope we never get there, but it's the only way to allow more fluid out of the eye and thereby lowering the pressure. Again, the goal of glaucoma treatment is to preserve your vision. Unfortunately, these days, we cannot transplant an eye. The optic nerve, the cable that connects your eye to your brain, it has all the blood vessels, and it has 1.1 million different connections that come from your brain. Each one has to be attached correctly in order for you to see. So unfortunately, we do not have full eye transplantation these days. So what you got with your vision, we're trying to preserve. I think a good way to conceptualize glaucoma and the treatment, right, is imagine a train that starts in New York and it's going all the way to San Francisco. New York represents full vision, no problems with your vision, and going to LA or San Francisco for various reasons is blindness. Think of the train goes along. Our treatments, the drops, the laser, the surgery, is designed to slow down the train. Unfortunately, all of our treatments do not stop the train or put it in reverse. The train always goes. So that hopefully, by the end of your lifetime, you will have barely crossed Chicago. So again, we are trying to preserve your vision with glaucoma, and that's why it can be a little bit of a difficult disease.
How long does the laser treatment last? I'm asking because I've had both.
Yeah. The laser treatment, the data says after 5 years, about 75% of patients still do not have to take drops or have a repeat treatment. But again, that's kind of like an average, you know. When it works great. There are some people where it just doesn't work, and that's happened to me, yes.
I've had
Question?
it for 3 years.
Sorry?
I've had it now for 3 years. The laser treatment.
And still have not had to have drops in the eyes, correct? Right? So you're right in the average, yep. 75% of patients, you know, close to 5 years, no further treatment, which is great, yeah. There are so many different types of glaucoma. Everyone can get some form of it, right? Glaucoma is referring to damage to the optic nerve. It could be trauma related. You can get in a bad car accident or punched in the eye, and that can induce glaucoma. Diabetes can induce glaucoma. There are certain types of medications that cause glaucoma. So it's difficult to say, like, you know, but like I said, people that have the low pressure version of glaucoma are often Far Eastern. Chinese, Korean, Japanese. Unfortunately, glaucoma is very prevalent in African Americans. There is a separate type of glaucoma that's very common in Scandinavians and Eastern Europeans. Again, a little different for everyone. Any other questions? Yes. Floaters are in a different part of the eye. It's kind of in the vitreous, which is the gel that's kind of gives our eye volume and everything. I have floaters too. I have 3 and 2. It just happens with time. The floaters are in the back of the eye. Cataract is in the front of the eye. So the cataract surgery will not improve your floaters. You know, oftentimes when your cataract is ready to come out, you probably don't even notice the floaters because the cataract is so bad. And then we replace it with an artificial lens. People say, oh, I have floaters. They were there already. Just now that you can see so much better, you can see the floaters now. There is a surgery for it, but it carries a lot of risk, and the benefit is often not worth it. I counsel my patients, less surgery is better. Just time. Just time. It's debris. It's just sorry? Hey, I'm in my 30s and I have so many floaters already. It just, you know, it just happens. Yeah, but it's kind of debris buildup that just happens with time. I think that's just a very simple explanation without getting into the weeds.
You said that glaucoma, I mean, different type of nationalities get
Different types. Yeah.
So does it depend on your diet? Like for me, I'm African-American.
Mm-hmm.
So does it, I know a lot of us get cataracts and glaucoma and stuff. Does it depend on what you eat, your food, your diet, or whatever?
I think
That
just,
has something to do with
yeah, I mean, overall, having a nice, healthy diet is very helpful, right? I'll kind of get into diet in the eyes in a separate condition. That's very important. But making sure, try to reduce your processed foods, right? Green leafy vegetables, low salt, right? There is not a one-to-one relationship between high blood pressure and high eye pressure. But yes, there is a correlation. If your blood pressure is sky high, yeah, your eye pressure is probably going to go up. But each point of blood pressure does not equal 1 point of eye pressure. But having low blood pressure or well-controlled blood pressure is very important for the overall health of your body and also the eyes. Yep. There are so many, but I would say the most common one that we make sure that you understand that there is a risk is a medication called Topamax. That's the brand name, and topiramate is the generic name. It's a condition. It's a medication that's designed to kind of help the brain with certain things. So if that medication sounds familiar to you, then please go over it with your eye doctor. Yeah, but that's kind of the big one that really comes to mind. Anything else before we move on to glaucoma? We can at the end. Yeah. Oh, where are we here? All right, macular degeneration. Macular degeneration. So we're going back to our image here, right? This is your retina, right? We just talked about your optic nerve. Immediately adjacent to it, there is a region of your retina called the macula. It is like the film of the camera, captures the image, turns it into a light. Captures the light, turns it into an image. This is where our central vision comes from. Macular degeneration is in the name, where this starts to degenerate. The full diagnosis is called age-related macular degeneration. Unfortunately, it is more common the older that we get. So what happens is that inside the eye, in the first picture, right, everything was clean. Now you have all these little yellow dots here that represents debris and buildup that is unable to be cleared over time. Just think of the garbage trucks that are full and they're leaving behind trash. Those little yellow dots are like trash bags that are still on the sidewalk. And then it will cause certain issues with the center part of your vision, which we'll get into. And then what is wet macular degeneration? There are two types of macular degeneration. There is the dry version, which is what I just showed you with the yellow dots. There is the wet version. Wet refers to bleeding. In certain individuals, if the macular degeneration gets bad enough, it can cause some of your blood vessels in the eye to leak blood, and that is how you lose your vision. And that is what our treatments are designed to treat. So you really don't want to get the wet version, and we'll talk about some of the treatments in just a bit. So this is a little graphic to kind of design to what happens with your vision with macular degeneration, right? We talked about glaucoma. It affects your peripheral vision. We talked about cataract. It's a general haze over your vision. Macular degeneration is the center of your vision. It will knock it out. So we're back to our photo. My lovely wife, right? We're looking down at her in the hallway and everything like that. What happens? Over time, you start to develop a blind spot in your vision. No matter where you look, you cannot look over it. You can't see behind it. It's very frustrating because it always is in the center of your vision. And that's why macular degeneration can be really devastating for just your overall life. Reading becomes very, very difficult. Driving, unfortunately, you can't drive anymore. So it can be very devastating. So what's the treatment? Prevention. Our three biggest things that kind of drive macular degeneration are smoking. Smoking is a big no-no. It really starts to degrade your macula, and any sort of smoking we really encourage no more. And that also includes vaping as well. Sunglasses, when you go outside, the UV light that comes from the sun is damaging. Just like UV light causes skin cancer and that sort of thing, and wrinkles and all that stuff, the sun can also damage the inside of your eyes. People that have blue eyes are more susceptible to macular degeneration. Because of their lovely blue eyes, it has less pigment. It blocks less light entering the eye. People with brown irises are a little bit better protected. So we do encourage you to wear a hat or sunglasses at the beach to be very helpful and protect your eyes from the sun. And the last thing that you can do, like we talked about, balanced diet. Having green leafy vegetables like kale, broccoli, spinach, they're high in certain minerals that will help protect you from developing macular degeneration. So you think of Popeye, can of spinach, all good for the eyes. Unfortunately, once we get into the wet version of macular degeneration, we have to treat it. The only way we can treat it these days is an injection, a needle directly into the eye. It is very uncomfortable in the beginning. You kind of get used to it over time, but it is quite frequent. I have it linked here that we can watch together. But it's not a fun experience. In the beginning, it's one shot every 4 weeks. Every 4 weeks, and it can last, up to a year at that interval. Once you kind of go down this route of injections, it usually does not stop. The goal of the treatments is to space out the interval of treatments. So in the beginning, you're at every 4 weeks, but it can go to up to about 12 or 16 weeks at a time, and that is the ultimate goal. But to get off the injections completely, I don't think is realistic for a lot of people, unfortunately. It's a very frustrating disease. Yes, please. Refrigerated those are often referred to glaucoma medications. They should be refrigerated in a bottle. The injections, again, is only by needle. There's no pill form. There's no eye drop form. There's no injection right now. Because of the medication, which I won't get into, it has to go directly into the eye. So these days, it's by needle. Yeah. Yes, please.
Why aren't we told about wearing sunglasses or a hat from the first time you go to get an eye exam? Because that's part of prevention. And I'm thinking about that because I have children, and they've never been told that. I was just told that a few years ago when I went to see a different eye doctor, and he said to me, "You like to go out, but you need to have on either a hat with a brim and sunglasses." And I'm just like, I'm in my 60s, and why wasn't I told that before? So I think that should be something.
Yeah, no, definitely. You're absolutely right. It's just like sunscreen and skin cancer, right? When you're young, a teenager, right? You don't want to wear sunscreen. You don't want to do this, Yeah. So it's definitely important. Yeah, I think.
What I think it is, I think now, today, more recently, we're getting more into preventative care.
Sure.
And at one time, go back 10, 15 years ago, nobody was really talking about preventative care.
Yep.
They were talking about treatments, things like that, but not preventative care.
Yeah.
And now today, we're more into wellness and preventative care.
Sure.
That's probably why no one has ever said.
Yep. And I would say I definitely reinforce it with a lot of patients that, again, have blue eyes, have a history of, oh, mom had this, she got the injections, like, oh, you should really definitely wear your sunglasses when you go out to the beach and that sort of thing. The fairer skins, the lighter pigment, that's really a big concern. I would say people with brown irises, it's lower risk, but you're absolutely right. Sunglasses is definitely very important and should be talked about more. And it's such an easy fix, right? Just sunglasses, right?
Should it be a special?
As long as they're UV blocking, you don't necessarily have to get the polarization, for example, right? But the UV is definitely important. And most you go to Sunglass Hut or something like that, most of the sunglasses there have UV blocking. All right. Well, I also want you to be able to drive. So, I want you to be able to see the road. So, yes, when you're at the beach and it's a cloudy day, you can still get sunburn. But, if you're actually in the car and stuff like that, most modern cars, the windshield has a UV coating on it. So you should be fine. All right. If you have any interest, we can play this video. I don't know if everyone can see it, but it's the video that you're referring to. Yes, it is a CDC video. It's a former smoker, and she's talking about her experience with the eye injections. It's, so if you're a little squeamish, you probably shouldn't watch it. But she's kind of talking about the whole process where we clean the eye, get it all prepped, and we get the needle ready, and the needle goes in. It's designed to be a little bit of a scare video, right? We want to scare you to stop smoking. And I think that's the most important, a very effective tool, unfortunately, is to kind of scare you to not smoke. So in the video, we use a little speculum to hold the eyelids open, and we numb it, we clean it, and then that's where the needle goes through. So not a fun experience. All right, we're on to our final topic that I've prepared tonight, which is diabetic retinopathy. So for those that may or may not have diabetes, your primary care doctor always tells you to go get your eyes checked, right? Go make sure you get your blood work. We check your kidneys, make sure your fingers and toes, everything's clean, that sort of thing. And you definitely have to check the eyes. And why is that? High blood sugar in your blood vessels, it causes your blood vessels to be really leaky. Or in this very, very small blood vessels, it can cause the blood vessels to actually shut off. And that's why you get the numbness and tingling in your toes. That's why parts of your kidney can get damaged from the blood sugar. And that's why the eyes, the tiny little blood vessels in your eyes get damaged. And that's what we have to check for. So this is a little graphic here saying that, yeah, the big ones are like stroke and heart attack and stuff like that. But in the beginning for the diabetes, in the routine checks, you should always get your eyes checked. Make sure your kidneys are tested with your blood work. And then make sure we're not developing any numbness and tingling on your fingers and toes. You hear about people maybe losing toes from diabetes because, yeah, the blood vessels got shut off. If there's no blood, how can it survive, right? So what do we see in your eyes? We're back to our normal picture, right? Again, this is a normal eye. Your optic nerve is very healthy. Your macula doesn't have any of those yellow spots or bleeding there, and your blood vessels look pretty good. These are pictures of diabetic retinopathy. There is blood everywhere. Blood leaks out of the tiny little blood vessels, causes you to hemorrhage, and will cause vision damage. It is all directly linked to your blood sugar. There are some things that we can do as eye doctors to preserve your vision, but at the end of the day, it is up to yourself to control your blood sugars. If your A1C is 12, 13, 14, 15, no matter what we can do with glasses and maybe some laser and stuff like that to help your vision, it's your blood sugar that needs to be controlled to make sure that your vision is preserved. So again, these are hemorrhages, these are little leaky blood vessels and everything like that. So that's what we really do not want to see. And it is unfortunately linked to all your blood pressure, your blood sugars. So, we talked about losing parts of your center vision, parts of your peripheral vision with glaucoma. Center was more macular, and the haziness with glaucoma. Depending on where your blood vessels are leaking, it can cause a combination of the peripheral loss and the central loss. It kind of depends on where the damage is occurring. So it's up to us to kind of diagnose where it is and what we can do to help you. Oh, take care. Thank you. Thank you for coming. So this is kind of what I'm showing here, is that the center vision loss, if you have bleeding in the center part of your eye, that is why that's occurring. If you have peripheral loss, as like in glaucoma, that is often due to the tiny little blood vessels that are leaking out on the edges of your retina. So again, it kind of depends on where the damage is occurring. So what can we do? Again, prevention, 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 right? Keeping your blood sugars under control, exercising, healthy diet, that sort of thing. Just know that if we do have problems with your retina, there is laser treatment for it. There are actually injections for the diabetes as well. It's not a fun experience, but again, the injections are designed to preserve your vision. The laser is designed to preserve your vision. Once you kind of go down this route, we never really get back to a full 100%. You always lose a little bit as we go along. That's why prevention is key, okay? And then, finally, Ozempic is a very popular medication these days. And then, Zepbound, Mounjaro, this whole entire class of medications. In the news a couple months ago, there were these medical reports that Ozempic can cause blindness. It is true. There are two major conditions that the Ozempics, the Mounjaros, the Zepbounds, they can cause. One is something called drug-induced uveitis. It is an allergic reaction that happens inside the eye, incredibly, incredibly rare. Once the medication is stopped, it goes away and your vision should recover. The second thing, it is a form of stroke inside the eye. It is incredibly rare. The reports and data suggest maybe 5 individuals for every 100,000. Incredibly rare. That's without using Ozempic. The data today and all the published reports are saying that it's maybe 8 to 9 patients out of every 100,000. Still incredibly rare, but the risk goes up twofold. So just know that if you do happen to be on the medication or you're considering starting the medication, just know that there is a very, very small chance that it may affect your eyes. But it's a great medication. There are plenty of people that have lost so much weight. Their A1C is like maybe 12, and all of a sudden they're down at 7. It's a great, yes?
So once you stop taking it, don't you gain that weight back or whatever?
Sorry?
The people that's like that Ozempic, once you stop taking it, don't you gain that weight back eventually? Just like gastric bypass?
Ozempic is designed to suppress your appetite. But once you stop, your appetite can come back. But it's up to your discipline to not indulge. Yeah. So it has to be kind of a psychological shift in your mentality, right? Yes, you're using the Ozempic. You don't feel hungry and that sort of thing. And that's why you're not eating as much, maybe eating a little bit healthier. But once you go off the medication, it is still up to you to do the right thing and diet and exercise, right? At the end of the day, you know, if you treat your body well, your body treats you right, right? So that's kind of all I have. Yes, please. Dry eyes, the bane of every eye doctor's existence. Yeah. We'll talk about dry eye instead. Yes, about diabetes or?
About dry eye.
Yeah.
We're not gonna let you leave.
I know. Can I do another lecture? Because it's going to take another hour. So why does dry eye happen? Your body, I mean, think of your body, right? When you're young, everything's really flexible, really strong. Your glands are producing, right? There is always tears being produced for your eyes to keep them well lubricated. If you do not have a good tear film, you will not have good vision. The tears that cover your eye is by far one of the most important aspects of your vision. So dry eye can be very frustrating for the clarity of your vision. It is often worse after any form of surgery. You hear about people having LASIK or PRK, laser refractive surgery, and they do have dryness afterwards because we're doing surgery on the eye. Cataract surgery. We have to cut the eye, go in and remove something and put something new inside. That cutting process is necessary for cataract surgery, but as a byproduct, it will cause some form of dryness. Just like dry skin, you put lotion on your hands and your face and stuff like that as a routine to prevent dry skin, to prevent the flaking of your skin. Using eye drops are very important to prevent or keep the dry eye at bay. Unfortunately, as we get a little bit older, it doesn't get better, unfortunately. I would say it's most prevalent in women after menopause. The lack of estrogen and progesterone, it just causes a lot of the glands to atrophy a little bit, and you just do not produce as much tears as you once did. For men, we just kind of get old. It's just, you know, yeah, you just don't produce as many tears. Also, the lack of testosterone can also play a role as well. There are many, many, many different types of over-the-counter eye drops. I personally do not care which one you use, as long as you use it. Just like there's CeraVe, Neutrogena, La Roche-Posay, Cetaphil, and different types of moisturizing lotions, there are many type of eye drop brands. As long as it does not have preservatives in it, any sort of lubricating eye drop is good for the eyes, as long as it has no preservatives. Yes, please.
My question is, I hear you saying, you know, all different kinds. Do you just keep trying different ones to find the right ones? Because my husband has dry eyes, and it drives me nuts that he's using these drops, and they, to me, they don't seem to work.
Yeah.
But he's just like, well, that's what the doctor said, and I'm like, I don't care.
Yeah.
They're not working.
Frequency and consistency is key. You cannot use it as needed if you have dry eye. Just like dry skin, right? Your skin is starting to crack, and then you start globbing on the lotion. You should have been using lotion every day for a week beforehand to prevent that, right? When we go into the winter, right, all that dry, unmoisturized, dehumidified air dries out the skin. It'll dry the eyes. We're kind of getting out of that season, thank goodness, but it's just kind of the daily hygiene of keeping your body healthy. There are prescription eye drops to help dry eye. They are designed to help your eye produce better quality tears. They are normally used twice a day. They tend to burn when they go in, but that means you got it in and it's working. Not all of them work for every individual. I would say the reason why we do not jump to prescription drops, in my experience in my practice, is because they can be very pricey. Insurances have a huge problem covering it, and insurance companies have a lot of problems covering other things, but they need to be used consistently every day, and a lot of them take about 2 months to really kick in. So if you use it here and there, you're not giving your eye a good chance to accept the medication and for it to be effective. The tear film has two major components, the water layer and the oil layer. A lot of the eye drops that are over the counter, the prescription eye drops, they are designed to supplement the water. The oil is also incredibly important for your tear film. The little oil glands right adjacent to your eyelashes, they produce the oil that goes over your eye. It is designed to protect the water from evaporating too quick, so that oil protects it from the dry air. If you do not have a proper oil layer, then the water has no protection and it'll just evaporate just like that. That's why we tell people, yeah, you should probably take some omega-3 vitamins over the counter. Fish oil is very helpful. If you don't like eating fish, then yeah, do the fish oil. But those supplements will actually help produce more oil for your tear film. Lutein is good. That is primarily for macular degeneration. Yeah. You can also find all these over the counter, of course. Now, I would say, there are some really advanced treatments for dry eye. There are a whole bunch of other prescription ones. I would say the most aggressive is something called serum tears. Do you know any athletes that have had platelet-rich plasma, PRP? Peyton Manning had it injected in his neck. A lot of athletes after a knee surgery, they'll get platelets injected or plasma injected into their knee and shoulder and stuff like that. We can take that same principle. Blood has your red blood cells and it has plasma. We isolate it, take that plasma, which is so high in your natural nutrients, we mix it with an artificial tear, and you use that as an eye drop. That is by far the most aggressive topical dry eye treatment I can offer you. But obviously, you got to go get your blood draw. They have to isolate it. They have to create it. It is frozen, and you defrost them out of your refrigerator, and then you use it until it's gone, and then you defrost another vial. It's very time intensive, but that is the biggest treatment I can offer you. So for you, as a patient, you feel like your vision is just fuzzy. You just don't have that crisp clarity with your vision. Just everything maybe feels like a film is over it, right? Sometimes you actually feel maybe like an eyelash is sticking you, a piece of sand, gravel, burning sensation. If it gets really, really bad, there is pressure behind your eye, pressure above your eyebrow, or below your eye, because all the nerves that are on the surface, they also run with these nerves, so it can irritate this entire area. I've had some people say that their dry eye triggers a migraine. That can be so bad. So that's what it feels like to you. When I look at your eyes, there are certain things that I can see. Have you been doing well with the drops, or you're still a little dry? And so it kind of depends on what I see.
I know a few people who have dry eyes.
Mm-hmm.
They say they're dry, and they drink water a lot.
Correct.
Dry.
When your eye is dry, your body senses it. What does it do to compensate? It puts out more tears. So if you add back the artificial tears and keep it lubricated, your body will not sense that dryness, and it should put out less tears. Yeah. Yep. Take care. Mm-hmm. Yes. Sorry, I didn't bring my cards. Makisha will give. I know. Makisha will give you the information, and you can either go to the website or just give the phone number a call, and either one of myself, my partner, Dr. Chang, and our optometrist, Dr. Chu, It's a little confusing, so sometimes I just go by my first name, Dr. Evan, since we have Chang, Chung, and Chu, and yeah, so. Yeah. Sorry. Do you have my card? Yeah. So yeah. No, I'm just joking. Yeah. Yeah. Yes.
How many times a year insurance allows them to come to you?
For a regular eye check, once a year. Once a year, yeah. If there is any medical problems like glaucoma, macular degeneration, diabetes, your medical insurance will take care of that. Cataract as well. Yes.
Can you just explain that again, the tearing to me? Because I have a cousin that I was just talking to her, and she said that her eyes were tearing so badly that
Yeah.
she stopped driving because it's like bloody. And she couldn't see.
Yeah, with people that have dry eye, the eye, all the nerves on the surface, they get all dry and irritated. It tells the body, oh, we're dry. We got to put out some more tears, and that will manifest as the tearing. But the compensatory tearing that comes out is not the correct consistency. So it can burn. It just feels like, oh, I'm just constantly dabbing. Some people have to carry around a box of Kleenex every day to dab their eyes and dab their face. So by using the artificial tears to supplement it, the body will feel less of that dryness and will feel less of the need to put out more tears.
So the artificial tears is actually better than the tears you put out.
Correct. No.
And how often should you put eye drops?
Personally, I use it 3 times a day. I use it once when I wake up in the morning, when I brush my teeth, when I'm on my break at lunch, and then sometime in the evening. I would say at the very minimum, twice a day is a good baseline. You can use as much as you want. You cannot overdose with artificial tears, just like you cannot overdose with lotion on your skin, right? But having a good baseline every day is very important.
When your eyes are red, what does that tell you? What does that signify?
When the whites of your eyes get dry, all the blood vessels get irritated. They get bigger, and that's what the dryness will cause, is the red eye. So when it's more lubricated, those blood vessels are not inflamed, and they'll shrink back to their normal size, which is not normally visible. Yes, please. Crusty? Yeah. Yep. Like I mentioned, your tear film has 2 components, the water and the oil layer. Overnight, the water will evaporate. It leaves behind the oil, and that's what crystallizes or crusts in the morning. And that's what the morning crusties are. It's usually clear. You know, people that have pink eye or infections in the eye, their discharge in the eyes is normally very green or very, very, very dark yellow. When it's just that clear kind of mucousy stuff, that's just your natural oil. That means you have to use more tears. Yeah, take some warm water. If you have some Johnson & Johnson baby shampoo, use that to clean your eyes. Johnson & Johnson baby shampoo is very soft. That's why you can get it in a baby's eye, baby shampoo. And then you just give it a nice clean, and then wash it away with some warm water. Okay? For the most part. Yeah. It depends on what you want. Yeah, I can do it however you want. It's up to you. It's your eyes. Yeah, when you use the monofocal lens, you either choose distance and then reading glasses, or glasses for distance, and no glasses when you read. Correct. If you want to stay like you are after cataract surgery, that's totally fine. Well, at the very minimum, the reason why we have to actually do cataract surgery is because you can no longer pass the New Jersey DMV test. And we have, yeah, I mean, there's some people that really don't want to have cataract surgery, and that's fine. But I have to take your license because you're not safe to drive anymore. Yeah, just think of a banana. You think of a green banana and a brown banana, and then one that's like perfectly yellow, right? We do cataract surgery when it's perfectly ripe. It's affecting your vision. It's not too advanced. We don't want to wait too long, and we don't want to do it too early. That's why we're saying, yeah, you have the cataract, but it's not ready yet because it's not affecting your vision, and it's not ripe enough to come out. Yes, progressive. Progressive. It gets worse with time. I really strongly advise that you do not wait until your 90s to get cataract surgery. Yeah. 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 Like I said, the oldest person I've ever done, 99. She wanted to wait that long. I was like, all right, that's fine. But please do not wait that long. It makes my life a lot harder. Okay? Just like a lot of orthopedic surgeons will not give you a new hip after a certain age, it's really difficult at a certain age. Correct. Just like in hip surgery, a lot of the bone is weak and cannot accept a new implant. Same thing for the eyes. It may be too weak. So that's why we really don't want to wait too late.
What's that magic age?
It depends on you. I mean, I've had some people that, 88, 89, and they're like, not that bad. But when they turn 90, I'm like, all right, let's do it now before, And I've had some people like, for example, today, 42-year-old, ready, So my father is 73. He's not close. My mother is 69, turning 70. She already had it 2 years ago. My aunt had it in her 50s. It's nature versus nurture, right? My aunt and my dad, brothers and sisters. My dad's in his 70s, still hasn't had it yet. And my aunt had it in her 50s, Same family, but different.
Some babies are born with cataracts.
Yes.
I know my girlfriend, baby was born with cataracts.
Yeah, depends on if it's in both eyes or one eye. And if it is in both eyes, we have to do it very soon, usually within the first 6 weeks of life. Yeah, but that is done normally by a pediatric ophthalmologist. And unfortunately, pediatric ophthalmologists are very rare. You likely will have to go, at least in this area, into the city. Yeah, to go to either Cornell or Columbia or something like that.
One last question.
Yes.
When it comes to night drive,
Yes.
and when it comes to glasses,
Uh-huh.
aside from anti-reflective coating, is there anything else?
Amazon sells these nighttime anti-glare glasses. They're this yellowish tint that can clip onto your glasses. I would say it's 50-50. 50% of patients are like, yeah, it reduces, it helps the glare a little bit. And other people said this was a waste of $20. So I can't say for sure. Some people really feel like it helps. And some people said it doesn't help at all. So the only suggestion I have for you is, go to Amazon, try it out. And if you don't like it, return it.
My problem is LED headlights.
Even me too. A lot of the SUVs, you're higher up, and it's really bright, and they feel like they're always pointed up, right? The old ones are always kind of pointed down, but what can I say? Yes.
Tear duct plug. What?
So your tear duct, when you cry, your nose runs, because all the tears flow from your eye to your nose, and that's because of a tear duct. If you have dry eye, you're lacking water in the eyes. So what can we do? We can put little plugs into the opening of the tear duct to allow the water to linger in the eye longer instead of being drained almost immediately. Just like, when you fill up the kitchen sink, right, and you put the plug on, right, it allows the water to build up. Same principle. They are either dissolvable or silicone. The silicones are not dissolvable. I can put them in. If you don't like it, I pull it right out. The other ones, they dissolve 3 to 4 weeks.